CPD accredited webinar, and that these webinars are streamed live on YouTube. And so we hope that is okay with you and the speaker that but second is that the advantage of having this streamed live on YouTube is that you'll be able to see or watch the video or the clip, read the presentation at your leisure, at your leisure later on. But also note that once you are in this webinar, it means that you've registered because you submit your full details, your name and surname and your practice number or MP number, and this information is sent to the relevant regulator, whether you're with the HPCSA or the Pharmacy Council or the Allied Health Professions Council and Nursing Council. So the details will be uploaded and you'll get your CPD certificate according to the requirements in your regulatory body. So there's no need for you to post your name and registration number on the chat box. What we require in the chat box is only Q&A, so comments that we request that you do whilst the speaker is doing the presentations. And so this evening we are quite excited that we have been able to get one of our own within the group doing the presentations and giving a talk. We've been fortunate that in the last few weeks, we've been having colleagues from the Clinics Health Group, and what's amazing that most of them come from September. Even next week, we'll be having a speaker from September Hospital. So it means something is happening at that hospital. So this evening, we've got a specialist urologist, Dr. Kadima Tshimanga. As I said, specialist urologist with a special interest in minimally invasive surgery. He is enthusiastic about the use of new technologies and in urological care. He also has a vast experience in treating both male and females with various diseases of the kidney, the bladder, the prostate, and men's health, as well as prostate, of course, in men, as well as children with congenital and acquired urogenital conditions. He has over 10 years working experience in urology at Chris Hani Baragwanath Academic Hospital, Charlotte Johannesburg Academic Hospital, and Helen Joseph Hospital, where I was some time back. His qualification that he's got an MBCHP from the University of Lumumbashi. I think some of us may not be familiar with the abbreviations there, but he's from the DRC, and he did his MED from Wits University, and of course the specialist qualification with the College of Medicine, the College of Surgeons, FC Urology. So this evening, we're excited to welcome you, Dr. Kadima Tshimanga, to speak to us about the minimally invasive management of renal stones. I was talking to one of the colleagues within clinics to say they didn't know that we've got a big problem with renal stones. Yes, when I was at Helen Joseph, I think it was quite a big backlog at the time. I'm not sure if you were there at that time with Professor Adam when we're trying to clear the backlog of renal stones. So welcome, and we're quite excited to listen to you this evening. Thank you.
Thank you very much, Tabila. That was a very thorough introduction. I'm Dr. Tshimanga, as said, and for this evening, I greet all the colleagues in attendance. And we're going to present on minimally invasive management of renal stones. So while you're waiting, I'm just quickly looking at the way of getting my full screen here. There we go. So just as an introduction, renal stones, as any other surgery from the beginning, it was open surgery to remove the stones. And because of the position of the kidney into the retroperitoneal space, it's usually an extensive incision about 10 centimeters into the flank or in the lumbar area. And those incisions were quite very aggressive, very painful incisions, and of course, quite a lot of complications. And over the years, we've seen multiple techniques and strategies to deal with stones. by trying to avoid those big incisions. So we've got a lot of modalities, a few modalities of minimally invasive surgery. But here, just to give a quick background on the renal stone disease, we say the lifetime risk is about 1 to 15% for any individual. And after the first episode of stones, the recurrence rate sits about 50% at 10 years. In children, they even more than that, about 35%, up to 35% in the 2 to 3 years. But this incidence depends on the race, the age, gender, and geographic location. Why? It has been found that into the white race, there are more prevalence of renal stones, followed up by the Asian and the Black people on the last result. The peak age is around 40 to 50 years of age, the 4th and 6th decades of life. Very seldom we see renal stones in younger than 20 years old or older. In the younger, usually it's when they've got a congenital predisposition, and the older ones, usually it's stones that have formed for many decades. They're growing slowly, or they became asymptomatic and chronic. But it does not mean we don't see a new stone formation in those extreme of age. So in the, depending on the geographical area, the temperature, hot, arid, and dry climates tend to favor stone formation. We believe here it's because of the dehydration due to the arid weather that leads to stone formation. And also obesity with abundance of fatty acids that leads to acidic urine, and that is also a good medium for urine for stone formation. The risk factors, as we are brushing them through, so we've got biochemical predisposition. That can be due to congenital or acquired conditions, such as hyperparathyroidism or chronic gastroenteritis. These acquired disease predisposition are also risk factors. The anatomical ones, usually it's when these anatomical anomalies cause a stasis of urine. This can be a congenital or acquired obstructive uropathy, it can be refluxing or a neurogenic bladder. All of this leads to a stagnation of urine and calcium or crystals deposition and stone formation. And one of the main cause nowadays, it's diet related. The westernized diet that is high in salt, oxalate, iron salts, such as takeaways and all the street foods. We've got the soda, fizzy drinks. They are very acidic. We also have foods such as chocolate that is very high in oxalate, same as spinach, tea, coffee. When we take them into excess, they lead to stone formation. The processed foods, and in people who do not drink enough water. So they run in dehydration, and this leads to concentration of urine and deposition of crystals and stone formation. So yeah, it's a quick, just a summary of the pathophysiology, how the pathogenesis of stones. So there is, first of all, the main components of stone formation is the change of pH in the urine and imbalance in solvent composition of the urine. So when there is either urine or acidic urine, both can lead to different type of stones. If there is hypersaturation of the crystals or minerals or salt in urine, it will progress to supersaturation. This leads to nucleation and crystal formation, and this subsequently lead to stone formation. And more stones form into the kidney even if we find the stone into the urethra, the bladder, the kidney, or the urethra or the bladder or the kidney, usually these stones are formed in the kidney and they do migrate downstream through the ureter, the bladder, and the urethra. Very seldom we have stones that are primarily formed from the bladder. So when it comes to the choice of treatment, once we have the stone, there are a few factors that come into play. Because of the different modalities, we look at the stone factors. Usually it's the burden, the size of the stone, the number of stones, and the composition of stones. I did not put a slide in, but it's good to know that we've got many types of stones. Usually we break them down into the one that you can see on X-ray or radio opaque and radiolucent. The main, the big portion of them are composed of calcium stones. It can be calcium oxalate or calcium phosphate. We have struvite stones, and we've got cystine stones that's usually found in children who are born with anomalies. And on the other side, we have the radiolucent one that we cannot pick up on the conventional X-rays, such as the uric acid stones and stones that are formed from indanove or xanthine. Those stones appears to be very low Ansfield unit or density. They're not visible on X-ray. Apart from the stone, okay, so we say the composition. On the stone factors, we also have the location. Is the stone into the kidney? The kidney itself, I think I'm going to show a picture here of the anatomy of the kidney because it has got many different calyces. Got the upper pole calyces, mid pole and lower pole, and it has got different strategies to approach those different location of the stone. It can also be into the ureter or all the way down into the bladder. The anatomical factors also play a big role. First of all, to know if the patient has two functional units of the kidneys. If we've got solitary kidney after previous surgery, it can be trauma to surgery or disease that they've lost one kidney. So this kidney, we try to salvage it at all costs. So we look again at obstruction into the system. It can be congenital or acquired. It can arrive at different level. This can be at the level of the pelvic ureteric junction into the ureter. It can be a proximal, mid, or distal ureter, or it can be at the vesico-ureteric junction. So, and other anomalies, we can be a PUJ obstruction. We spoke about it. Can be a diverticulum that's formed onto any part of the collecting system. It can be the pelvis or the calyx. It can also happen onto the ureter or into the bladder that is putting pressure onto the urethra, into the ureter. Or some congenital anomalies, such as a Pumbelli syndrome or refluxes or anything mega ureter, that can happen. We need to take that into consideration when we're treating this patient, because it can be a challenge for us to access the kidney through endoscopically, for instance. It can be a challenge for us to access the kidney transcutaneously. So we have to study and see which anatomy we presenting to us. And also some techniques that just to blast the stone, to fragment the stone and allow the urine stream to drain it. But if they have obstruction, it becomes a challenge for these patients to drain the stone. So we might need to privilege a technique that remove physically the stones and nothing is left behind to be drained. Also the patient factors, age, we need to pay attention, especially with the extreme of age. Pediatric patients present their own challenge, anesthetic challenges, and even surgical challenges. On the other side, the elderly patients, on the other extremity, we've got the cardiopulmonary comorbidities that can affect the anesthesia, the positioning of the patient on the bed, because different treatment modalities require different positioning. Sometimes it's quite extreme positioning that we have to give these patients. Is there infection, obesity? Because of the adipose, I think for the infection, it speaks for itself. Preferably, we have to treat infection as a matter of priority before we attack the stone. But on the obesity, also poses multiple challenges from the anesthesia even to the surgical technique. If we want to approach it transcutaneously, then we need to consider the distance between the skin to the stone. And this can lead us to choose which modality we should prioritize, and other comorbidities as for any surgery. So most of these patients present to the emergency department. Very seldom we see patients coming with non-symptomatic stone or stone that has been chronically sick. Chronically, they now and then they're having pain, resolving pain again. But most of the time, the bulk of these patients, they come as emergencies, presenting often with intermittent colicky flank pain. And that has got the characteristic radiation to the lower abdomen and the groin and the genitalia. Also associated nausea and vomiting. Hematuria, it's a very pathognomonic sign. Flank pain plus hematuria equals stones. That the hematuria here can be microscopic or macroscopic. Sometimes patients do not see it, but when we do the urinalysis, we pick up the red blood cells. In some cases, very few will present with dysuria or urinary urgency, restless. Some patients will report passing stone fragments or stone material. So when it comes to the diagnosis, we're gonna go through a detailed medical and dietary history, because we know diet is a big component of risk for stone formation. So the medical condition, pay attention to hyperparathyroidism, to pay attention to chronic gastroenteritis or sprue, which medication the patient is taking, what is the dietary habit. And on the physical examination, from head to toe, we should focus examination onto the abdomen. We feel usually the tenderness is in the flank, especially when the stone is higher up into the proximal ureter or onto the pelvic ureteric junction or the kidney. But sometimes the tenderness is lower down into the iliac fossa, especially when the stone is situated on the distal ureter or the vesico-ureteric junction. Very important to do a few testing, like blood testing. We need to look at the septic markers, white cell count, CRP, look at the renal function, urea and creatinine, because only these two elements can show us if we are dealing with an emergency or not. Because a stone, usually when we have these pains, it's because the stone is causing either obstruction or it's migrating through the urethra, through the ureter. So when there is obstruction because the stone is impacted at some level of the ureter, we need to make sure that the system is not obstructed. That is leading to renal function compromise. We need to make sure there is no sepsis that is developing in there. So once those two, or one of those two, is present, we need to consider it as a matter of urgency. On the other side, we need to look at the electrolytes, uric acid, and parathyroid hormones. So this is a summarized version of, we need to know the stone workup. What is possibly the cause of this stone? So we proceed to urinalysis. Mainly we want to look, because we said it's very important, hematuria is pathognomonic sign, flank pain plus hematuria. On the urinalysis, we put our focus on red blood cells and leukocyte nitrate. So and those ones. But we can take advantage of this moment to look at the pH of the urine, because that is very important. It's going to show us what type of stone can we expect. By knowing before doing any surgery, we can decide, can we treat it conservatively or not, depending on the type of stones, because only a few types of stones can be treated conservatively by means of dissolving the stone with medication. And review of the imaging studies. So we have a few pictures. I'm not sure if my pointer is being seen. In most of our casualties or our consulting rooms, most doctors have got sonar machines. It's becoming really the extension of the physician's hands. So on the two bottom images here, they are ultrasound images. The first one, it's very difficult to see the stone on ultrasound. Some skilled sonographers can pick up the stone, they can see it, but most of the time we see the complication of the stone. We can see the renal parenchyma, but the renal sinus is not completely collapsed. There are areas of black marks, so it's adenophysis. It's not a stone, but it's a complication from the stone. The stone is causing obstruction and dilatation of the collecting system. On the second image, that is on the bottom right image, demonstrating acoustic shadows. This is a characteristic image of a stone when we see it on ultrasound. It gives these acoustic shadows. So this collecting system is full of stones, and we can see like the sunlight running through the curtain. And on the right top, we have a KUB X-ray with the air. That is definitely a stone that appears white on this film. But this imaging is becoming a little bit a problem for investigating stone patients. Despite having the X-ray, we're going to still need a CT scan, because when we look at the stone, there are a few information that we need to have in possession before we go for management of the stone. We need to know the exact size of the stone, the position of the stone, the functionality of the kidney affected by the stone. We have to look at the contralateral kidney. What is the functionality on CT scan? So that's why it's becoming a bit obsolete image. We request most casualty doctors to proceed to the CT KUB straight away, instead of adding more radiation to the patient. Like we can see it on the left-hand side top image, the X of the CT scan at the level of the kidneys, demonstrating a stone into the right renal pelvis, the pelvic ureteric junction. We can see dilatation of the collecting system compared to the contralateral side. And if we look closely, you can see there is around the kidney, there is fatty stranding, demonstrating that there is pressure into the kidney, there is inflammation ongoing. So when it comes to the option of management, so we spoke about the first one, that is conservative management. So the second one is ESWL. It's an extracorporeal shockwave lithotripsy. We've got the URS, RIRS, or erythrorhinoscopy, and retrograde intrarenal surgery. The PCNL, it's a percutaneous nephrolithotomy, and laparoscopic surgery, also one of the options. So when it comes to expectant management or conservative management, the indication usually is when we have a small stone that is less than 5 millimeters situated into the distal ureter. Yes, so we've got a 5 millimeter stone situated into the distal ureter. There, where the studies have proven, when we give the medication as muscle relaxants, they act more onto the distal part of the ureter, allowing the dilatation of the ureter and the spontaneous passage of the stone. So for us to embark on that modality of treatment, we need to make sure that the patient came with pain, and this pain is responding to basic analgesia or oral analgesia, and there is no overt UTI or sepsis that is secondary to that stone. And there is no evidence of renal compromise. So here we look at the urea creatinine if there is changes or not. So MET, it's a medical expansive therapy. So what is advised to give this patient is alpha blockers, such as Kajura or tamsulosin. These are alpha blockers. They act as muscle relaxants to relax and allow dilatation of the ureter with safe passage of the stone. So, and calcium channel blockers also play the same role. So here, after the prerequisite has been present, we can embark on this management, give the patient a urocap. So if they pass the stone during micturition, they can catch that stone into the urocap. And this procedure, this modality can be allowed only to take place up to 4 weeks. Beyond that, we need to intervene. So when it comes to emergency management, a few indications. So if we pay attention to what we said already, the prerequisites for expectant management is just the opposite. If we have refractory colicky pain, so for these ones, they're not responding, we have to intervene, we have to disobstruct. Uncontrolled nausea and vomiting. The patient become parexial or overtly septic. The infection is spreading. Patient with a solitary kidney with stone. So we cannot wait for 4 weeks, waiting for the stone to pass, while we know we cannot put this kidney at any risk or danger. We have to salvage it at all costs. Or if there is obstruction with renal dysfunction. So as emergency management, some patients will come already dehydrated because they've been vomiting or they are septic. So we start by resuscitating them, cover them with broad spectrum antibiotics, collect urine for MCNS, blood for cultures. Then as we doing that resuscitation, we have to proceed and get a mean of disobstructing. So 2 options, either we put a double J stent, we also call it ureteric stent, or we call it again JJ stent. This one requires to be taken to theater under anesthesia. It can be regional or general anesthesia through endoscopy, cystoscopy, and insert this JJ stent. As you can see, the JJ stents here, the blue picture, there's get a coil on top, coil at the bottom. And when we put it in the patient on this KUB X-ray, we can see the one coil sitting into the collecting system and another coil sitting inside the bladder. So that way it does not move up and down. So by inserting that DJ stent, urine will drain. So we're gonna bypass the stone, allow the kidney to drain, and allow the sepsis to be treated. So same thing happens in a closed system, such like any other abscess or collection. Closed system, antibiotics do not penetrate, and sepsis can only progress. So by disobstructing, we drain the system, which can allow to treat the sepsis and treat the pain. But for a patient who was not fit for surgery, not fit for anesthesia, or a theater not available, another option is to put a percutaneous nephrostomy tube. The advantage of this one, we can have a large bore, pigtail, that we can insert, especially if there is inside the kidney, that we can put transcutaneously. We can do it with sonar guidance or fluoroscopy. It can also be done under local anesthesia. So we don't have to put the patient through anesthesia or to theater for that. And after putting a JJ stent, it's going to allow dilatation of the ureter, and definitive therapy usually intervenes in the 7 to 14 days. So we're going to go through the modalities that we just listed before. So we're going to start with the extracorporeal shockwave lithotripsy, or ESWL. So what it does, it uses ultrasound shockwave that is applied on the flank and very close to the kidney with a fluoroscopy, because you can see a C-arm is there. Fluoroscopy, they can focus the shockwave on the stone, and they allow it to break the stone. It usually takes 45 minutes to 1 hour and a half or 90 minutes to break the stone. As you can see on the images here, the stones are big on this first picture of the kidney, the second one, and the third one, they fragment them in small pieces. So the indication for this one, guidelines like that we're following, a lot of guidelines suggested as a first-line option for treatment of stones, renal stone or proximal ureteric stones that are less than 2 centimeters. So the mechanism of action, we say it's using ultrasound waves, shock waves. It focuses. So by repeated shocks, it weakens the stones, and that's how it ends up blasting the stone. So these are the descriptions about the settings that people use. Just one mention here is for people with arrhythmia, sometimes we have to change the shockwave frequency to the heart rate, so we synchronize it to prevent cardiac complications. So the stone-free rate. So if we assessing these modalities of treatment, we look at the stone-free rate. That is very important to know how good this procedure is compared to the next one. The stone-free rate with a stone that is less than 1 centimeter, it's about 90%. And the 1 to 2 centimeters, it drops to 80% because much bigger stone, plenty of fragments. And more than 2 centimeter, it's less than 60%. So this is not good enough. That's why the recommendation to the guidelines, it's a stone that is less than 2 centimeters. And the stone position also, we have to look. The stone, pelvic stones, we have about 84% stone-free rates. In the upper pole, about 90% because of the gravity, the stone fragment drain easily. Into the upper ureter, 70 to 90%. It's debatable there, but the lower pole stones, they are not part of these ones because depending on the position of the lower pole calyx, most of the time it's not a good indication because the lower pole is dependent position. It's very difficult to drain those fragments after they've been broken into pieces. So a few contraindications. The absolute contraindication is obesity, because these machines usually work better when the stone to skin distance is less than 10 centimeters. Skin, even internal bleeding. Sometimes we see them coming with, because it's causing a little bit of renal contusion, they present with hematuria, and this clot can cause obstruction and becoming another emergency to deal with. If there is a distal obstruction, that is going to hamper the drainage of fragments, UTI or overt sepsis. Patient with congenital, skeletal, renal, pulmonary, or calcified aneurysms, all of those will be contraindication. Even a pregnant woman also, pregnancy will be a contraindication. On the relative side, we look at the stone burden. Of course, we said it's indicated for stones that are less than 2 centimeters, but we might have a bigger stones in a patient that for other reasons, we decide to go with this procedure or to use it as sandwich procedure. We start with the ESWL then we do another modality, then we come back to do EWL as multiple session of procedure to lead to stone clearance. So high stone density. So the stone, if it's too hard, it's going to be difficult to break. And a previous failed ESWL, and sometimes anomalies of the kidney. So the list of complications, I'm just going to rattle through them. It can be a renal colic because of the contusion, hematuria, renal injury, subcapsular hematoma, transient adenephrosis, dermal ecchymosis, Stenstrus. Quite interesting, Stenstrus, it's translated in English as cobblestone road. So when we have plenty or multiple stone fragments, they drain into the ureter and they jam, and causing the obstruction of the ureter. So it's one of the most common complications that we see with ESWL. The reason why some people put a stent in after the procedure, but most urologists do not put the stent in. Sepsis can develop afterwards, or hemoptysis. So the second modality will be ureterorhinoscopy or retrograde intrarenal surgery. So starting with the sketch on the left-hand side, we can see there is a straight scope. We call it a rigid or semi-rigid ureteroscope, indicated for stones that are lying onto the distal ureter, mid, but seldom, very seldom, it can progress all the way to the proximal ureter, even into the kidney. But well indicated for distal and mid ureter. So we can go in, do the ureteroscopy, we can see the stone. But when the stone is sitting up into the kidney, it's much easier to go on the picture on the left-hand side. We've got the flexible ureteroscope that can easily go and navigate through the anatomy of the ureter all the way up to the kidney. The picture here, we just see the stone that has been cut into a stone basket. So this instrument, we feed them through this instrument port. Here also we have the instrument port that is sitting there. That's where we put the lithotripter. That's where we put the instrument and everything. So on the ureteroscopy, described since 1929 by Young, it's also considered by some guidelines. If the ESWL has been advocated by the European Association of Urologists guideline, the ureteroscopy is being advocated as first line of management by the American Urology Association. These are the two big association of urologists in the world. And here in South Africa, we're using both guidelines to assist us with the decision. So we've seen increase in use. Most people prefer using this one. It's available for pediatrics equipment. We have the flexible, the rigid and semi-rigid ureteroscope that's help as I demonstrated on the previous picture. And the indication, this one is very good for impacted stones because we can see the stone that is not able to be broken by ESWL. But by seeing it under vision, we can deploy a laser or any lithotripter and break that impacted stone. Also advocated for hard stones. Usually they are the calcium oxalate monohydrate and the cystine stones. That's the hardest stones we have. It can help with both renal and ureteric stones. And we can also use it for stones that are refractory to other modalities of treatment. So it requires a GA, general anesthesia and paralysis, and uses different sources of energy, such as the ultrasonic lithotripter. It can be a ballistic, it can be pneumatic, it can be electro-hydraulic, but most commonly used nowadays is the holmium laser. So let's say laser because they also have a thulium laser, the pulsatile thulium laser that can also do the work. But this is the most commonly used. It can crack any type of stones, any solidity of stones. Laser usually get through them. It is a safe modality and non-significant complications. So for the considerations, we said it's a more popular since miniaturization of the equipment. We have it in any sizes. We can have a 4.5 French to 9.8 French of a ureteroscope to access the kidney. So it's indicated mostly for kidney stones less than 2 centimeters, and it's got a high stone free rate. So after surgery, we managed to up to 91% of clearance of stones, and the complication rate is about 10%. So this for distal and mid-ureteric, we say we use the semi-rigid, and the upper ureteric, we're using the flexible because you can navigate through the anatomy. And to improve the irrigation, because we're using irrigation to progress the equipment, we usually put in an access sheet that allows in and out irrigation to flow, and improving the vision and decreasing the pressure onto the kidney. And yeah. So the third modality, it's PCNL, or percutaneous nephrolithotomy. So this time around, we do not go retrograde. So it's not going from the urethra up to the kidney, but we go through the skin to the kidney, percutaneous nephrolithotomy. As you can see on the sketch here, so through the skin, we put an axial sheet straight into the kidney, facing the stone. We put a nephroscope, and you can use the different modalities, energy sources, almost the same as we use for the ureteroscopy. But here we have the advantage of using a large bore. So if the access sheet that we're using for ureteroscopy is up to 15 French, here we can use 24 up to 30 French. So it allows for much bigger instruments to go straight into the kidney, and this one can deal with much bigger stones because we have much bigger and powerful instrument we can put in there. So as we said, it's emerging, emerging as the preferred modality for larger and complex calculi that are more than 2 centimeters. So it is now an alternative to open surgery and laparoscopic surgery. We can tackle any size of stones. So most often it's used as monotherapy with good clearance or stone-free rate of up to 98%. But in some cases, depending on the anatomy of the stone and the kidney, it might be used in a combination modalities. We call it sandwich approach. Most of the time we use ESWL. So we break the stone in small fragments. We do a PCNL. We remove the fragment. We break it into smaller pieces. Then we can do another ESWL. We can do another ureteroscopy to make sure we mop up all these fragments from the kidney. And also, it's not only larger caliber of access we have. We now have much smaller. So we call it mini, micro PCNL, even nano PCNL, even the size of a needle to access straight into the kidney and aspirate the stone from there. It is a safe procedure with high stone rates, stone clearance rates or stone-free rates, as we said. So the favorable factors compared to open or laparoscopic, because it's a much smaller skin incision, usually 1 to maximum 2 centimeters incision. Of course, we might have multiple, 1, 2, 3, but usually one incision is enough. Single step dilatation, access the kidney. We don't have to cut through the muscles. We just dilate them. And good access, even in pediatric patients. And the hospital stay is much shorter compared to open surgery. So the types, as I was saying, we have different types. It can be a standard one when we have a 24 or 22 to 30 French access into the kidney, so it's quite a big one. We can do a mini PCNL with a difference. So every society has designed their own sizes, so there is no like standardized nomenclature on them. That's why we give all these numbers. But usually from 11 to 22, we know it's a mini PCNL. It can also be a micro PCNL, where the telescope working channel, the irrigation, all are combined in a needle around 4.8 French. So this one also we can go a single puncture or multiple. Does not even require any dilatation at all. And the mini micro PCNL, it's in between the mini and the micro, sitting at about 8 French access to the kidney. So the challenges with this one is how to get access into the kidney. It's not that easy, but a few techniques. It can be fluoroscopy guided, it can be sonar guided. And the positioning of the patient can be supine or it can be prone. So we need very good imaging. So CT scan to make sure we see the anatomy. So we take the straight path to the stone through the calyx, making sure we do not go through any other structures. That's why we need to have a CT scan and study the anatomy before going forward. It requires GA, and you can see on the previous picture here, the fluoroscopy. We can call it the retrograde mapping. So we put contrast in the kidney to see the collecting system. Then we can access with this access needle, the Chiba needle, to access the collecting system. Then proceed with dilatation and put the sheets and start working on the stone. So as we said, the access can be through either this fluoroscopy guided, or it can be sonar guided. When we have a dilated system, we put a probe, we see the calyces, and we puncture. Okay, so what are the indications as primary modality? It's usually when we have a stone burden that is high, more than 1.5 centimeters or more than 2 centimeters, or staghorn calculus. This is a staghorn calculus. It's a big stone that fills up the renal pelvis and calyces, at least 2 calyces. Or when we have a lower pole stone that we say it's into the dependent position, usually difficult to drain, and the retroscope also struggles to bend and go into the lower pole. It's much easier to access percutaneously. So when we have a patient with anatomical anomalies, where there is impaired drainage or access by a retrograde way, for hard stones, such as cystine and the big stones, struvite, brushite, all these stones with a big size and high density, it's a good modality because you can use much bigger access and much bigger instruments and much more powerful energy sources. And also we use it for those stones are referred to all other alternative procedures. So the contraindications, if there are anesthetic contraindication, or if there is atypical bowel interposition, so we have usually what we call retrorenal position of the bowel. But when it comes to the absolute contraindication, we can look at them: coagulopathy, active UTI, anatomical anomaly that precludes access, non-functioning kidney, malignancy, or if the skill levels are low. It requires a little bit of training. So looking at these 3 modalities that are most commonly used by the urologists, the question is which one one would use. So I just picked up this paper published 2015, which is the best treatment of pediatric upper urinary tract stone among extracorporeal shockwave lithotripsy, percutaneous nephrolectomy, and retrograde internal intrarenal surgery. So it's a systematic review, meta-analysis of 13 studies. So the findings, it's confusing, but almost saying the same thing. PCNL, that appears to be superior to ureteroscopy and ESWL. No, to ESWL. So the single session of ureteroscopy is more than ESWL, but the overall stone free rate is similar. So there's no significant difference between the PCNL and ureteroscopy when it comes to stone-free rate. And the PCNL has got the highest effectiveness quotient, and unfortunately, it got the longest hospital stay, up to 3 days on average. Efficiency rates than ESWL and PCNL. A bit confusing, and probably that's what makes it difficult to decide which modality to use. And surgeons most of the time rely on their own experience, the skills they have, and the equipment. Just to add up on it, the PCNL requires quite high equipment usage. It's quite expensive in terms of equipment consumption. So the other modality that we could figure out is laparoscopy or laparoscopy-assisted surgery. So despite the advances in PCNL, ESWL, we still have 2 to 17% incidence of laparoscopy due to the factors that is listed there. So usually in adults, we have about 2%, but in pediatric population, up to 17% of PCNL. So the lack of experience to use the PCNL, ESWL, but mostly PCNL. The lack of instrument, as we said, it's quite costly in terms of instrument to use. The burden of pediatric anomalies, this is for the pediatric population, and the stone-free rate more than 96% when we do laparoscopic, because we can do laparoscopic nephrolithotomy, we can do laparoscopic ureterolithotomy. We just open up the ureter and grab the stone and remove it. So the clearance rate of stones about 96%. So it's not proposed as the first step, like initial treatment in most cases. So we use it for refractory stone, and the indication would be the primary failure of primary therapy in very young children with complex stones, or impacted or large ureteric stones, gas-containing calculi. If we've got stones into the calicid diverticulum, congenital malformation, if we've got orthopedic impairment or abnormal position of the kidneys. And open surgery, what everyone is trying to avoid, remains almost indicated as a salvage procedure, or can also be used for larger complex bladder stones. They still use it, but mostly as salvage. After we've tried all other modalities, they failed, we end up with open surgery. Or if there is unexpected complication arising during a procedure, it can be converted to open surgery. So on this table here, just probably a summary of everything that we spoke about. It's giving the stone location, and it's giving the stone location, the modality options, and the alternative or second line treatment. And there is a comment there. So they break the stone into less than 1 centimeter, 1 to 2 centimeters, and more than 2 centimeters, and they locate it and see which modality is the best. And here also, it's organigram describing the way we can approach these stones. So this is basically a summary of everything that we're suggesting, which modalities are for 1.5 millimeter, less than 1.5 to 2, and more than 2, which modality is best when it's into the renal pelvis or into the lower calyx. We say it's a very challenging one. And different modalities have been proposed, PSWL, PCNL, and so on. Again, yeah, it's when the stone is into the ureter, but here they add also into the bladder how to access it. So this was everything that we planned for today. Thank you very much.
Thank you very much, Dr. Tshimanga, for this a detailed presentation on management of renal stones, and it was just a great overview with a lot of emphasis on within areas of management and also that you intervention that can be made to manage these kidney stones. My apologies for my connectivity. I've got a very poor connectivity this evening. There are a few questions that we have that have been posted on the chat group. The first one that I have that I can read now, can you help me? I think I lost the first question on my laptop. I can only see the one that I'm seeing that on my connection here. How is laser used to treat bladder calculus?
Sorry?
How is laser used to treat bladder stones calculus?
So again, the bladder stones, of course, there is endoscopy management. It can also be a percutaneous or open surgery. But when we use the laser, we use it through a cystoscopy. The laser is indicated when we have a stone basically less than 5 centimeters diameter of stones. Because when we have much bigger stone, it takes so long. And by taking too long, we prefer not taking more than 90 minutes on a case, because the risk of infection, risk of fluid absorption is much higher. So the laser is contact. We use Olmem laser. And so there is a ballistic effect, but most of the time it's weakening, breaking the stone, and that's how we clear it. But when the stone is much bigger than 5 centimeters, we opt for other modalities to remove it.
There was another question. Unfortunately, I can't see it. Kamu, if you can help me with, there was a first question that was posted earlier on. If you can read it for us, Kamu.
Hi, Doc. I actually WhatsApped you the questions, but Doc, the question says, please explain how the CT scan is used to assess functionality of the kidney. What's the gold standard for assessing the functional status of the kidney, which I suppose is done before nephrectomy when indicated?
Okay, so a CT scan is an anatomical image. It does not give you the real function of the kidney, but it gives you an impression. So when we have a kidney with a sizable renal parenchyma, so we can assume there is some function of the kidney in that system. But if you want to have an accurate, when there is doubt, when you have thin cortex, we have a very thin cortex. So we doubt the functionality of the kidney. And then a nephrogram, this is a nuclear medicine scan. A nephrogram is used to give us a real function, or it can give us the split renal function. It's going to tell us the right kidney or the diseased kidney probably is having 30% contribution to the overall renal function, and the contralateral kidney is 70% to make it 100%. So the nephrogram is the one that is giving us the real renal function. But by doing a CT scan, we have an impression. It can give us an idea. We screen that kidney. We say, this is a functioning kidney. We can also look at the CT scan and say, this is most likely not functioning kidney because there's lost the renal parenchyma.
Okay, thank you for that. Yeah. The next question is, which types of stones can be dissolved and by which drugs? And I think there's a follow-up question to that. Which drugs are amenable to dissolution?
So when it comes to dissolving stones, not all stones can be dissolved, as we said. So we have the uric acid stones. That's we usually dissolve. And the cystine stones also can be dissolved. So for the uric acid stones, changing the pH of urine is very, very important because these stones form into acidic urine. Usually when we have uric acid stone, we have pH of urine that is below 5. By alkalinizing it, by means of using drugs such as potassium citrate or sodium citrate, we can achieve a pH around 6.5 to 7.5. Then adding to that, we have to increase the fluid intake to facilitate that. So when it comes to the cystine stone, I think we're going to alkalinize the urine as well with the pot seed. And we need a copious amount of water, fluid intake per day. It is described up to 5 liters per day to drink, to attempt to, and in some cases, use penicillamine to try and dissolve this stone.
Okay, thank you very much. I think there's in GP practice, there has been a tendency to use citrus soda to manage renal problems. Is that a good practice, or what's your advice? Patients coming in with urinary tract with renal problems.
So there is a bit of controversies on citrus soda because there is sodium in it. So even when we give an analyzer, we're preferring staying away from the sodium citrate because the sodium itself mimic the role of calcium into the proximal collecting duct into the kidney. So they compete with calcium when it's time to resolve the calcium and leading to uricemia, hypercalciuria. So high concentration of calcium in the urine. That's why even the diet, we're trying to decrease the intake of salt, of sodium. That's why the citrus soda, despite it being like a wonder, most people being chronically on it, patients automedicating themselves, it's not a great drug to use urinary problems, especially when we have stone predisposition or stone problem in these patients.
Okay, I don't see any. Okay, go ahead.
The citrate is a good. I think it's not a stone promoter, but it prevents stone formation into the colon system. The citrate part of it.
Okay. No. Thank you very much. I don't see any further questions on the chat box. But this has been a good presentation, and I think that's been quite valuable for most of us. I know that this presentation is there on YouTube and people can access it. But are you amenable to sharing your slides? Sometimes we get asked this question quite regularly.
No problem. It's not a problem.
Okay, so you shared that with myself or Kamo.
Yeah.
No, thank you very much, Doc. Yeah.
Thank you very much.
Yeah, I don't know if I can see myself. I try to make sure that but I just want to say thank you very much for this wonderful presentation that you've shared with us this evening. And I'm glad that I'm stating that everybody who's been connected here has enjoyed this presentation. And we thank you for sharing your thoughts with us. And just want to thank all the colleagues who joined us this evening also for joining us every week. That it's quite heartening and encouraging to see so many of you joining us every Thursday for these presentations, and I trust that you're getting a lot from these discussions that we are getting from people like Dr. Tshimanga, who do valuable work in our practice, in our hospitals. And I just want to thank you for the team that is working with us, Kamo from the marketing team, Togo, to making sure that we get these presentations. Is there a way maybe that you can share with us how to connect with you? If there is anyone who wants to contact you?
Yeah, see, my numbers are not there, but I can share my contact with you. But otherwise, I can be on the straight line from Tepotemba Hospital. But I'll share my contact details with you. I don't know if there is a them.
Yeah, that's fine. Yeah, that's okay. But thank you very much for spending your time with us, and thanks a lot, colleagues. We appreciate your support every week when we bring good speakers in our midst. And have a good evening. Thank you very much.
Thank you.